about drug binds to the receptor and everything, we have to know about the drug receptor binding and the drug receptor response curve. So how the drug that binds to a receptor have a different mechanics and also different outcomes. The biological outcome that can occur secondary to the drug receptor binding based on the affinity and the intrinsic activity of the drug that can cause after the binding. So we have to know two terms here, affinity and intrinsic activity. Affinity is how avidly a drug binds to a receptor. This depends on their structural similarity of the locking mechanism of a drug to a receptor. Okay, so this is how avidly a drug can bind to a receptor. Next is intrinsic activity or efficacy. This is magnitude of the effect of the drug once bound. Once a drug already bind to a receptor, the cellular response and biological outcome that can come after that decides the intrinsic activity, whether they can reach the 100% biological response, only 50%, or nil, or they go negative. So that shows the intrinsic activity or efficacy. When a lower dose of a drug can reach a higher biological response, that drug should be called potent drug. It means you only need a smaller dose to elicit a maximal biological response. That is a potent drug. So potent drugs are very good because you only need a smaller dose to achieve a best efficacy, but they are very risky because any overdose of that drug can cause a toxic effect as well because they are highly potent. Okay, so next we have to talk about agonists and antagonists. Agonists are drugs that once bind to the receptor, they bring about biological response. Means they are efficacious. They can bring about good intrinsic activity. They are called agonists. Okay. The biological response can be either stimulatory or inhibitory based on that drug. Okay. So as example, when you talk about inotrope and beta receptors, when you have your beta 1 receptor, that intrinsic activity will be stimulatory, GS. Okay, that is also called agonist. But for GI for opioid, morphine is agonist at the GI receptor. So when a morphine joins to a GI receptor, it causes full inhibitory effect. So also a maximum efficacy. So agonist doesn't mean only stimulatory. Agonist is a drug that bring about the desired biological response. If the desired biological response is stimulation or activation, if it brings about maximum, that is a full agonist. Okay, so full agonist will have a good affinity and good intrinsic activity. They avidly bind to a receptor and they bring about the maximum biological response. Partial agonist means they have a good affinity, but they have less intrinsic activity. They don't reach the maximum potential efficacy like 100%. Antagonist is a drug that have a good affinity. They'll bind to a receptor, but they have zero intrinsic activity. Okay, there's another term called inverse agonist. We will go into that. So again, just a recap. So agonist bind to a receptor. This is agonist, binds to a receptor and full activation of the receptor. When you have agonist and antagonist, this is a competitive antagonism. We'll talk about later. Antagonist is bind to a receptor and there is no activation. So when we talk about intrinsic activity, this is what I mentioned. So we talk about here around 30% is basal activity. Basal activity means the activity of a receptor at a baseline even without a ligand binding to it. Without the ligand binding, a free receptor may have a basal activity without any ligand binding to it to potentiate it. So in this case, the graph is around 30%. So look at it. So 30% is the basal activity of a receptor without any ligand binding. And then we administer a full agonist. Okay, we administer a full agonist. A full agonist is a drug that have a good affinity and maximal intrinsic activity. So the full agonist will increase the receptor response and biological response to 100%. So they are full agonists. This is the drug receptor response graph. This is the drug concentration As the drug concentration increases, a full agonist can reach 100% response at a certain dose. Next, we have a partial agonist. Partial agonist has a good affinity, but even though despite increasing the drug concentration, they cannot achieve a maximal response. They can only achieve a certain response because they can only activate the receptor partially. It's not strong enough to cause a full activation. Next is antagonists. Antagonists are drugs that keep the receptor at the basal activity level. They don't reduce it, but they don't increase it as well. So what does antagonist does is, antagonist, once the antagonist has bind to the receptor, it prevents the agonist binding it and increasing the biological response. So they maintain it, the receptor activity at the basal level. Next, we talk about inverse agonist. Inverse agonist is reduces the receptor response below the basal level. So let's say in this graph, the basal activity of this receptor is around 30%. By administering an inverse agonist, it actually brings down the basal activity below, okay, from 30% to up to a 0% if you keep increasing the concentration of the drug concentration of the inverse agonist. Okay, this is just a repetition. So as I mentioned, the good group of drugs to read about, to give an example about all this, is should be opioid. So when we talk about full agonist, you have either methadone or morphine. All these can cause a full agonist effect. Okay, full agonist effect. So now here we talk about reversal of opioid. Opioid overdose, you want to reverse, or patient with opioid addiction, you want to reverse. You want to give some substitute, right? So when you give methadone, so methadone is a full agonist. So it's a short maximal effect, while buprenorphine is a partial agonist. You see, you need a lower dose. Even at a lower dose, methadone can reach a 100% response. But buprenorphine, even at a higher dose, only reaches a partial, less than a 50% of the efficacious or intrinsic activity. Okay. Your full agonist can be a very potent one or less potent one. Full agonist can be a drug which can reach the maximal effect at a lower dose, as I mentioned, the potent one, or less potent. They also can reach the maximal effect, but you have to give it a higher concentration. So graph will move right side. A potent drug will have a graph which is on the left side. A less potent drug will have a graph on the right side. Then you have antagonists such as naloxone, which does not increases the intrinsic activity. Keep it at the basal level. So again, so when we talk about maximum efficacy is your Emax. EC50 is effective concentration to reach the 50% of the response. Okay, 100% response, 50% response. So we have a drug A, which is a full agonist, which is a very highly potent. Okay, so it has a lower EC50 to reach the 50% of the response. And at the lower dose, at the certain dose, it already reaches the 100% maximal pharmacological effect. Where we have a drug B, which is only a partial agonist, despite increasing the drug dose to the same level as the drug A, it only can reach a limited pharmacological effect. So the EC50 of a drug B is the drug that those that need to reach the EC50 is higher. So it's a less potent drug. So we can say here the same thing here. As a drug is less potent, the curve will move towards your right side. If it's a drug with a full agonist, but if it's a less potent, it will eventually reach the 100% pharmacological effect, but it will need a higher drug concentration. But if it's a partial agonist, it will never reach the maximum pharmacological effect despite increasing the drug concentration, these two. Okay. So drug A is potent than drug B in terms of both are full agonists, but drug C and D are not full agonists because despite increasing the drug concentration, they will never achieve a maximum effect. So this is just repetition. Go again. So we talk about antagonists. Antagonists, we have competitive antagonism. irreversible or non-competitive antagonism, or we have a allosteric antagonism. So what is competitive? Competitive, as the name suggests, they compete with the agonist for the binding site. So this is your receptor binding site. Agonist binds here usually. A competitive antagonist will compete to the same binding site, preventing the agonist to bind. Okay, that is competitive. The common example is non-depolarizing muscle relaxant with your acetylcholine. This is your atracurarium with your acetylcholine. Okay, the moment atracurarium has bind to the nicotinic receptor, there is no binding. Membrane acetylcholine receptor. So NMJ receptors, there is no binding of acetylcholine to facilitate contraction. Okay. Next, we have an irreversible or non-competitive antagonism. Okay, non-competitive. It means the antagonist bind to a different site, or it doesn't actually bind to the same receptor binding site. It doesn't compete with the competitive with the agonist to the binding site, but they causes irreversible or non-competitive antagonism. So why is it irreversible or competitive is called reversible is, in a competitive antagonism, let's say you give 100 molecules of antagonist, competitive antagonist, there were 100 molecules of ACH. So there's an equal competition. So the competitive antagonist can prevent the binding of agonist. But if you increase the concentration of agonist, if you increase the molecules of agonist, like acetylcholine molecule become 200 now, they can successfully displace the antagonist from the receptor binding site and bring about the pharmacological effect that we wanted. So they are reversible. Irreversible or non-competitive antagonist is, since the antagonist not fighting for the binding site with the agonist, increasing agonist concentration might not bring about the effect intrinsic activity that we wanted. Okay, so that's why it's called non-competitive and irreversible, like a ketamine at NMDA receptors. Next, we have allosteric non-competitive antagonist. It means these allosteric antagonists bind at a different binding site. They have a different binding site in the receptor, and by binding at the different binding site, they causes conformational change in the receptor. They causes a structural change in the receptor, which causes a change in the receptor drug binding site in the receptor, so the agonist cannot bind. The allosteric antagonist will bind at a different binding site than agonist, causes a conformational changes, leading to difficulty in agonist to bind at the receptor binding site. So that is benzo at GABA A receptors lah. Okay, benzo, when it binds at the GABA A receptors, it causes a non-competitive allosteric antagonism. So again, this is your receptor. Agonist can bind, competitive antagonist can bind. Agonist alone, this is your, again, drug receptor response curve. So you will be asked to show this in presence of just now. Okay, again, sorry, I have to go back. Just now we talk about this is drug receptor response curve in the presence of full agonist, partial agonist, and inverse agonist and antagonist. Okay, so here we talk about drug receptor response curve in terms of agonist alone, in terms of antagonist, competitive antagonist present, and irreversible antagonist. So if you look at it, this is agonist alone. Okay, your acetylcholine receptor alone, you get 100% biological effect, contraction. Okay, this is your contraction. Then you have a competitive antagonist. When you have an agonist plus competitive antagonist, you can still reach the 100% biological effect, but you have to increase the concentration of agonist. This is what I said, competitive. When you increase the concentration of your agonist, it can fight and displace the competitive antagonist and bring about the 100% biological effect. But when you have an irreversible antagonist, which is a non-competitive antagonist, despite increasing the concentration of agonist, you will never reach 100% biological effect. And as I mentioned, allosteric antagonist binds to a different binding site, prevents the agonist to bind here because there will be a structural change in the binding site. So next we go to drug-drug interaction. There is a 4 main terms that we have to know. We talk about antagonism. This is not a receptor antagonism. These are called drug antagonism. One drug antagonizing another drug's action. So additivity is a combination of two or more chemicals with the sum of the expected individual response. So additivity is 1 plus 1 is equal to 2. You are just giving two different drugs to achieve a enhanced biological reaction. But it's not supra additive. It's just 1 plus 1 equal to 2. The reason why we are doing this is because we don't want one drug given at a very high dose, which can lead to toxicity. Example is inotropic use in ICU. When a patient already on a shock, already on NORAD, above a certain limit, like a 1 mic of NORAD or anything, we will always go to a second inotrope, because increasing a certain inotrope against a supramaximal will cause a severe vasoconstriction leading to gangrene or reduce the tissue perfusion and periphery and everything. We don't want, so we will go to a second. So additive effect. Okay, 1 plus 1 is 2. Why we do this additive? Because we don't want the certain drug, one single drug, increase in concentration causing toxic effect. Okay, next. We talk about potentiation. Potentiation is one drug appears to have no effect when given alone, but increases the potency of another drug. Exposure to one chemical results in other chemical producing effect greater than given alone. One drug, if you give, only can produce 70%. But if you given along combination with another drug, this can bring about 100% of pharmacological effect. Okay. Next, we go about synergism. Synergism is supra-additive. 1 plus 1 is more than 2. Okay, 3 or 4 like that. Combined effects are greater than sum of the effect. If that individual drug given alone, if combined, they can given a better supra-additive effect. Exposure to one chemical causes a dramatic increase in effect of another chemical. Okay, so synergism also called supra-additive effect. So when you talk about synergism, potentiation, and additive effect, you must know examples for each of it. Okay, so in terms of when you talk about your additive effect, they talk about mida and ketamine. So this example can be very vague, and different references can give a different example. Please go through on your own and come about few examples. So in terms of SAQ, you can quote. You have to write few examples. So for synergism per se, the most commonly we will talk about is your mida and propofol. Okay, mida and propofol is considered a synergism. So when you given both, you don't have to give higher dose of both. By having a supra-additive effect, you can reduce the dose required of the each drug. Okay, instead of giving both at 10 mg or 10 mg per hour, you can cut down both of it. Okay, to 5 mg, 5 mg to achieve the similar effect. Okay, that's about it. In terms of additive, they do mention about mida and ketamine. Okay, it's also the same. And then you have a synergistic effect and also your potentiation. So please read about and think about your examples for each of it. So this is the isobologram. So isobologram is a drug that shows this drug-drug interaction. So we have a drug A and drug B. If it's additivity, you can see when you give a drug of drug B at 50%, drug A at 50%, it still reaches in the middle. So it's 1 plus 1 is 2. Okay. Synergism is supra-additive. Supra-additive means by giving drug A, increasing and combining drug B, the dose required from both the drug is lesser. See, as the drug is more potent, lesser dose of each drug is required. So the graph will go left. Antagonism is the other way around. So drug A, increasing concentration, drug B is your antagonism. To achieve the maximal response, your drug A concentration have to go higher and higher and higher. This is your isobologram. Okay, whether it's concave or convex or linear. Additive will give a linear graph. Antagonist will give a convex graph. And a synergistic drug will go for a concave drug. So you have to remember this. Okay, please read and importantly think of an example, at least 1 or 2 examples for each of these drug-drug interaction. We have talked about why this is important. The drug-drug interaction is important. Again, we go to our therapeutic index. So why we want to maintain a therapeutic index is we want to prevent a toxic side effect. So as I mentioned at the earlier part of the slides, your pharmacodynamic is best maximal dose with minimal and best with maximal therapeutic effect with minimal or no side effect. Okay, so we have to find the right ED50, effective dose 50, and to prevent a therapeutic dose of 50% as well. So we have talked about it last time, just a recap of this lah. Okay, so by maintaining a drug in a therapeutic range, we will achieve a maximal pharmacological effect. So we won't be in the ineffective part and we won't be in the toxic part as well. Miscellaneous, this is for own reading. So you have to know these terms as well. What is tachyphylaxis? Tachyphylaxis is repetitive administration of certain drug causes reduce in pharmacological response due to down regulation or exhaustion of your receptors, like as ephedrine. You give multiple time, the pharmacological effects comes down. It could be because all the drug receptors are saturated or down regulation, because ephedrine is an indirect sympathomimetic. So by binding the receptor, ephedrine binding to a receptor, it causes release of internal endogenous catecholamine. So multiple administration of it causes exhaustion of endogenous catecholamine. So you give multiple ephedrine doses in a short frequent of time, there is no replenishment of the endogenous catecholamine, so the maximum pharmacological effect won't be elicited. Desensitization is another term that we have to know. It refers to a chronic loss of response. This is not acute. Tachyphylaxis is acute. Desensitization is over a long period of time and may be caused by structural change in the receptor morphology or absolute loss of the receptors. So desensitization occurs over a period of time. It could be because of the damage to the receptor, structural change in the receptor, or it could be because of the loss of receptor. This can happen in myasthenia gravis when your autoantibodies destroys your NMJ receptors. Okay, that's one of the example. So it also can happen with the in case of loss of beta adrenergic receptors from the myocardial cell surface in a continued presence of adrenaline dobutamine. If you give infusion of adrenaline dobutamine for very long time, like few days and over, the myocardial cells might lose or the number of your beta adrenergic receptor. Next, we talk about tolerance. Tolerance, best example in terms of opioid. The definition would be a phenomenon whereby larger doses are required to produce the same pharmacological effect. For example, at 2010, a person only required 2 mg of morphine to abolish the pain. But over the period of time, because he abused opioid, later on he needed a 10 milligram of morphine to get the same desired effect. So that is considered tolerance. Why tolerance happens? There is a lot of hypotheses. It could be because of reduction of receptor density, or it can be because of the receptor affinity to a drug. Okay, it could be number of receptors reduced, or the receptors present at the same level, but the drug affinity to the receptor reduced. And there are few other hypotheses as well. Please go and read about it. And then there's another term as down and up regulation of receptors. When a drug is given in a very large dose or anything, and as a pharmacological effect has reached a maximum level, we have an internal compensatory mechanism where our cells can down regulate the receptor. As I mentioned, as we talk about your tyrosine kinase receptor. So when there are a lot of ligand bind to the enzyme link receptor, the activation of enzyme might not occur all the time. So it might get down regulated or up regulated based on the phenomena. So please read about that as well. So that's all for pharmacodynamic for tonight.